This video is sponsored by the Association of Anaesthetists, A-Line, Health Education Northeast, and NEMO.
Our next presenter is Dr. Mumtaz Patel. She's a consultant nephrologist at Manchester Royal Infirmary, and she's a postgrad associate dean with the Health Education England Northwest. She's recently been appointed as the Global Vice President of Royal College of Physicians and has formerly worked as a regional advisor for training and clinical lead for quality management for the Joint Royal College of Physicians Training Board. She has done an extensive work on differential attainment, and today she will give us a talk on differential attainment. Please, Dr. Patel, take away.
So thank you so much for inviting me as well. I've really enjoyed the presentations that I've heard so far, and I hope this is helpful, and I'm sure the discussion afterwards will be really helpful as well. So I'm going to talk about differential attainment, which is something I've been working on over the last few years. Thank you so much for introducing me, and that's the different roles that I do. So what I hope to do in the next 20 minutes or so, and hopefully then keep to time with our schedule, is try and raise awareness of some of the current research work, evidence base around differential attainment. Hopefully try and give you a bit of a flavour of how we can understand the challenges of addressing differential attainment, and then more importantly, explore strategies to address differential attainment at a more programmatic and cross-specialty level, which is where I've been focusing on over the last few years, and hopefully again provide a framework of potential interventions in order to narrow the gap and improve outcomes. So how did I get involved with all of this piece of work? So as we were saying, I've been a consultant now for about 12-13 years now. I've had various medical education roles, and one of the things I started doing as an education supervisor, training program director, is managing a lot of trainees who were running into difficulty of different sorts. And in addition to doing that, so that was kind of part of my master's research project in trying to identify trainees who require extra support early. And then one of the bigger pieces of work I did with the in my HEE role was to look at trainees who run into difficulty, but then when you look back at previous data, what are the kind of identifiers that you can find. So the GMC, this was a joint collaborative project, evidenced long-term progression data, which also evidenced differential attainment. So these were the groups of doctors who were requiring extra support, the ones who were being referred up to the GMC, the ones from the previous presentations that you've been discussing today. And certainly when you looked at it from the E&D perspective, there was big differences between the referrals upwards. And then on a national level, in my Royal College role, I looked at the state of physicianry training in the UK. So this looked at various outcome markers, ARCP outcomes, exam outcomes, recruitment data. And basically, when you look at all the data from the E&D perspective, there were marked disparities at all levels, from recruitment to progression, ARCP, exam outcomes, and even up to consultant appointments, interviews, similar to what has just been presented here. And then now we're looking at further studies to understand the educational environment, because I want to move away from a negative deficit model. I don't feel it's a problem with individuals. I think it's a wider issue of how we can better support individuals as well. So I've been involved with the EDI groups from the HEE perspective, the GMC perspective, and now the Royal College perspective as well, just to give a wider view. And from the differential attainment side, we've been a pilot site for the regional rollout data, which I'll talk through in a minute. So what is differential attainment? So differential attainment, in a nutshell, unexplained variation in attainment of groups of individuals with shared protected characteristics compared with those who don't have those shared protected characteristics. The way I like to look at it is more of a fairness model. So the fairness in education, as defined here, is making sure that these kind of personal or social circumstances are not obstacles to achieving educational potential. And I think, this is a lot of where my work comes in, is how we can maximize the potential of each individual to attain, and those barriers, or artificial or actual barriers, should be, broken down. And when you look at the scale of the issue, you know, I think this is always a striking slide. And this was one of the slides back in 2014 where I put my hand up in a big meeting to say, I've seen these figures many times, but what are we going to do about it? And I think that action planning is really important to drive the agenda forwards rather than just talking about it. But basically, we know that different groups of doctors progress through training at different levels. It exists at all measures of progression, but the postgraduate exams is where it's the widest gap. So UK-wide graduates, 75%, goes down to 63% pass rates in UK BME groups, somebody like myself, born and bred in the UK, but still, apparently the numbers say we're still not attaining as well. And then the international medical graduate group at 41%. So we know it's existed for decades. It's not easy to address, and sometimes it's put in that too difficult to address box. But what I'm trying to say is that there are things that we can do. And yes, there may be discrimination and bias, but I think to look at it as a whole and address it as a whole to move forwards. I've always found this slide quite helpful in trying to understand what differential attainment means. So in my own practice, from an individual style perspective, so as a supervisor, if you look at the smallest box, I think, you know, we can all make a difference at different levels by understanding learning styles, culture, how we interact. And I talk a lot about a more holistic approach to educational supervision, where you look at the wider factors and how we can support better. The middle group is where, I guess, in my HE role, I'm involved with recruitment, induction, support, selection, as well as the assessment ARCP process. And I think those kind of things that, you know, again, we can change within those systems as well. And then on the bigger sort of picture-wise, from the national level, I think, again, from my college role, I found it's quite helpful to be involved with the discussions around policies, exam structures, assessment. And I think that's kind of, again, the way we could kind of drive change as well. So why is it important? So I think it's important at all levels, both on a moral argument basis, as well as, you know, kind of at, you know, the right thing to do. So from the GMC perspective, obviously, we're legally required to investigate these issues. The responsibility from the HE trusts and the providers to ensure fairness and equity to all. We know we all lose out if, you know, individuals don't receive the support that they need and don't achieve their potential. And we need to ensure that any of these barriers to progression are addressed, are looked at, are fair, justifiable to protect our patients. And if there is bias, discrimination, as been discussed today, then we need to address that quickly and try and eliminate that over time. And of course, over time, what we want to see is that these rates of progression improve and change. So again, the key objectives, not just for the GMC, for all of us, would be to build capacity in organisations to try and improve the design and delivery of education, but also learn from, you know, the current best practice, raise awareness of barriers and enablers, publish data. I think data is still really powerful. Whenever I do these talks at every different level, some people still don't acknowledge as an issue. So I think data is powerful to at least make the point, but then we need to drive the change by understanding, as well as, you know, kind of promoting innovative ways of looking at these things as well. And that collaborative approach. So a lot of the work I've done is with the GMC, with the college, with HE, with trusts. And I think that's what makes, hopefully, you know, kind of things sustainable going forwards rather than just quick fixes which are going to go away. So metrics for differential attainment. So when you look at the differential attainment outcome data, it's based on the ARCP outcome data, exams, and overall satisfaction score, which is used as a marker of your educational environment. And the data is given at a specialty and a training program level. So this is a busy slide, but this is kind of the data that you get. So if you look where it says combined specialties, so a bit like where you get your red triangles, green triangles for your GMC survey, it's similar to that. So basically saying 95% below outlier, your reference point is the UK white population. So if you look at this, ARCP outcomes are from the BME versus the white group are significantly lower in the BME group, both for ARCP, for exam, and for overall satisfaction score. Versus the white versus the EAU, the European group, again, differences in ARCP exam. And then the international group, again, the same. So this is kind of the level of data that you get, and then you can tease it out. And this has kind of been the premise of a lot of the work that I've been doing over the last few years. And I guess when we come to the discussion points, what I would like you to think about and hopefully share is kind of issues, what kind of issues you feel may contribute towards differential attainment, on top of the things that I've been discussing, both from your specialty program and trust level. So we can all have a think around that. But more importantly, what can we do to narrow the gap, both at an individual level, a local level, a regional, or a national level, if you have those kind of roles as well. And I think each of us in each of our kind of roles can make a difference, and small things, big believer of small things, can drive a bigger change as well. And when you think about different causes, so it's all so interrelated, relationships at work, kind of how we learn, the relationship with seniors and peers, and kind of how it impacts on identity. So I talk a lot about identity. So I'm BME, female Muslim background, second generation in the UK, not from a privileged background, far from. So, loads of things interact. And, again, it's how the system, the wider support that we can provide to enable those kind of perhaps barriers to be broken down over time. So if you think about it from a vulnerability process versus a protective process, so if you think about things like poor relationship with seniors, how can we change that? Well, time, if you actually give that bit of time to get to know individuals, have faith in their abilities, again, moving away from that what's wrong with you deficit model to say, how can we better support you to make that difference? And working along those lines. A lot of my work around the trainees requiring extra support was that fear of being labelled as problematic, so then they wouldn't raise concerns, and then the support wasn't there, and then they ran into trouble with other things. And that moving away from the stereotypes and other things, and getting that kind of further support in with all these different measures as described here. And this was a piece of work done by the work psychology group that I work with also within my wider work. And this looked at programs where the differential attainment gap was less. So how can we, how do those programs function, and what are the good bits out of it? And the important things, again, this is not rocket science, where diversity is valued and where individuals are valued, people do better. Looking at the learning pathway as a continuum from undergraduate to postgraduate. So I do undergraduate roles, and again, it's trying to kind of join them up a little bit better. And who supports learning? So things like inspirational leaders, that always comes up, role models, supportive trainers, what supports learning, maximizing the value of learning, and all these things. And again, like I say, it's how can we drive those successes, thinking about it in this way, which is what I would, wish others to take away from. And then when you think about interventions, how can you think of those? So the way I've mapped a lot of the work that I've done is mapped to the GMC themes and standards of postgraduate medical education as shown here. So I think the learning environment and culture plays a huge, huge part in how we can better support individuals as well. So what can we do to make a more inclusive, supportive educational environment? How can we strengthen the educational governance and leadership and make sure things are fair, make sure the options are available to all? From the supporting learners side, what qualities are they important in educational supervision? And I do a lot of work around unconscious bias training, as well as cultural competence, cultural safety. How can we better support our trainees, as well as better support our educators? And then a lot of work still needs to be done and is underway in a lot of areas around our curricula and assessment. And these are the kind of things I'm involved both at undergraduate level with the medical school stuff, but also with the postgraduate training curriculum with the colleges as well. So what kind of things have I been doing? So this kind of regional data was shared with us a couple of years ago. And based on the analysis of that, I started targeting schools and programs which were both positive outliers as well as negative outliers, and learning from the ones who had the narrow gap, and then trying to implement the good practice in some of the other programs as well. And then I've presented at various meetings, more so to raise awareness, and again, promoting this more cross-collaborative approach, both at a research level, evaluation, quality improvement. So loads of different pieces of work which are going on at the moment, and kind of that wider sort of circulation of the message as well. I've delivered various series of workshops, both regionally, nationally, etc. But within the region, we focused on the core groups, first of all, the core trainees, thinking that if you try and address some of the issues in the core trainees, then potentially, that will drive into specialty training. And some of my work has been in foundation as well as undergraduates as well. And we're working with Edge Hill also to develop an EDI kind of module, not the tick box mandatory training kind of one, more of an inclusive education module where people can bring in, kind of specific examples. And what we want to do is then empower individuals to take back into their organizations what they've learned to, again, drive change as well. I think research is really powerful. So we've been doing scoping exercises as well as systematic reviews to understand where the gaps are in research, as well as identify what the questions are to develop this work further and then develop interventions for further study. And then we were successful recently with this kind of programmatic approach of looking at differential attainment this year. And this is this work focusing on core training programs in medicine, surgery and psychiatry, with a focus on early identification, intervention and support. And we're proposing a modified pilot of the CSA SOX model, which is the clinical skills assessment model, which was in the GP trainees, which basically was looking at targeted exam support, a learning needs analysis tool, and then supporting a tailoring sort of support to individuals to drive and improve success, both in exam, ARCP, and overall outcomes. And I think it's really important to link any work from trainee development to educator development as well, to make sure that we're developing or upskilling our supervisors to improve that personalised support for trainees. So the intended outcomes for this piece of work is to improve the ARCP exam and overall training experience. We're hoping to develop a potentially transferable model to other healthcare programs as well. And it supports the workforce strategy as well as our long-term kind of people plan as well. And this is the kind of strategic approach that we're working on. And again, I'm sure this is not completely brand new to everyone, and I'm sure lots of people are doing loads of good work in this area. So if you're looking at it from a regional or program perspective, you can think about how recruitment, selection and placement works. We're doing a lot of work on earlier identification of trainees in different ways, and particularly around routes that you can identify, the CREST route, people coming in with alternative training certificates, and then trying to look at allocations based on their needs rather than scores. So for example, in foundation training, people who have the lower scores then go to the furthest away placements, and is that the right thing? Is that where they get the most support or least support? And the networks, we know the networks and family support and other support is really important to trainees. So how can we better do that? Enhanced program of induction, and in conjunction with that, focusing on the educator development aspect as well. The early assessment of risk or need for support. So some of my earlier work was looking at how we use workplace-based assessments, supervisor reports, recruitment scores to develop a model where we can identify trainees who may need that additional support early, rather than waiting for the ARCP outcome to be unsatisfactory later in the year to then target the support. And we know not one size fits all. It's a multiple set of targeted interventions which will be the key. So what are those interventions and how can we put those into play? And this is kind of just a bit of an outline of the kind of things that we've been doing. So we've got engagement from our School of Psychiatry, Medicine and Surgery to take this program forwards. I think the evaluation aspect is key, because where a lot of programs have run out or not shown success or sustainability is where, kind of the impact would be. So I think evaluation is a key aspect. And so we've been focusing on early identification and support. We've delivered various enhanced induction programs. We're working on questionnaires and earlier sort of support, learning needs analysis kind of tools. And then we've got a stepwise approach, as I showed on the earliest sort of slide, where we're doing educator development programs and then trainee specific interventions as well. And I guess that just gives you a flavour of the kind of programme of work which is currently ongoing. And I think this learning needs analysis tool, so we're trying to develop something on a virtual platform which will aid the initial evaluation of trainees and help plan their programme of support and then tracking progress as well. And we're on a 3-phase approach at the moment, so we're doing the scope and literature review around it, and then we're going to do some focus groups and semi-structured interviews of target audiences, which will inform our methodology and hopefully help with development and testing the tool. And as I mentioned before, the formal evaluation of any programme is key. That's where it's lacking at the moment. So a lot of good practice in lots of different places, which we're trying to collate, but trying to evaluate that and show key effectiveness longer term, which will then enhance the sustainability as well. And how can we do that? So I think a mixed methodology approach is important, whether it's, you know, your hard outcomes, your ARCP exam outcomes, but also that qualitative data evaluation I think is really important, and a longitudinal follow-up of trainees to capture more longer term outcomes. So in summary, I think these are just kind of top tips, I think, for trainers and individual trainees and students. Simple things, recognising diversity, I think, is key. The data I hope I've shown is important to both make the point, but also drive the change as well. I use the workforce argument quite a bit with my stakeholder engagement exercises to say, if we don't support these trainees, we have a huge workforce problem. You know, we need to value these individual trainees, maximise their potential, and that will do good for all of us. A lot of my work has been around earlier identification and support, and certainly mentoring, role modelling, those kind of interventions we know work, and it's trying to embed those and trying to have a much more holistic approach to trainee performance rather than that negative connotation it has, to trying to move away from that. And again, for individual trainees and students, empowering them to speak up, providing them with the resource and the guidance and the support early, and giving feedback, which I think is hard, but can be done in a constructive way. And it has to be a two-way process as well. So I hope, in summary, I've covered my outcomes as I set out, as in raising some of the awareness of the current research work, the challenges, exploring some of the strategies, as well as hopefully providing a bit of a framework of potential interventions in order to narrow the gap and improve outcomes. So thank you so much for listening, and hopefully we can have a nice discussion in the next part. So thank you.